Many thanks for asking me to come to speak today. It's a great pleasure to be here. And many thanks and congratulations to both of you for putting together this meeting. It's an extraordinary achievement. Well done. I'm glad and happy enough to report actually that I have not been biopsying synovium for 30 years. But I did my PhD at St. Vincent's Hospital and University College Dublin with Doug Veal as one of my PhD supervisors. And I've done about 400 arthroscopically guided knee biopsies of synovium. I put down Aurelie and Doug's name here just to tip the hat to them, because actually a lot of the work that I'll be presenting has been, in part at least, helped by them. Now, so I know that I'm the only thing keeping you from your lunch, so I promise two things that I'll try and stick to my mandate, although there will be a little bit of overlap with what some of the other speakers have already mentioned. And secondly, I promise I'll keep to time. There's a few things I do want to go through. I'm going to ask the same question that we should be asking on a recurrent basis and return to that theme. Why do we biopsy synovium at all? What can be studied in the tissue that's retrieved? How widely performed is synovial biopsy? I want to look at some of the key features of the ESSG Agenda and look at the current recommendations surrounding synovial biopsy that are currently published, but more importantly, at their limitations. And then I want to discuss again the elusive definition of tissue quality. I think this is one of the major themes that I wanted to show you, the heterogeneity in both analysis and in the reporting of data in synovial research. I'll take you through some examples of those. And then look at concentrating pretty much exclusively on hematoxin and eosin staining, as well as on immunohistochemistry, the proposed scoring methodologies that are widely reported. We give some examples of that and then look at the synovial pathotypes that are fairly well described at this point by Cospastalis, Francis, Humby and others. Then we'll do a little bit of exemplar scores for immunohistochemistry from data that we have. And then look at recent efforts of the ESSG, and in fact in that instance we'll be just revisiting some of the things that Roger has talked about regarding Aurelie's work and Doug Veal's work, seeking consensus on methodologies. So to return to the same question, I know there's about a half-half split between people primarily interested, should I say, in clinical aspects and those interested in translational or basic science research. But the question is relevant to us both. We biopsy synovium to help address the major current challenges in translational research and in clinical practice. And these have been articulated by Ursula Fearon as securing early diagnosis for the inflammatory arthritides, developing personalized, or I prefer to use the term stratified pathway where we can prognosticate accurately and get the right patient on the right medicine at the right time, as well as an empiric, objective way of appraising outcome with certainty. And to that I add that we get a significant understanding of the pathobiology of the disease by examining the tissue at source. Remember that the main target tissue of rheumatoid arthritis or the inflammatory arthritis is the actual synovium. And if you go to a dermatologist with a skin problem that's not clear to them, they'll biopsy it. Bernard has mentioned this before. You go to a gastroenterologist and they see an abnormality, they'll biopsy it. We have sadly been late to the game in that. And I'm optimistic, although we're not quite there yet, that we can advocate for everybody to have synovial biopsies. But I'm optimistic that we'll find biomarkers that will be useful in the clinical setting, actually. So biomarkers are the key. They're the strongest, most optimistic methodology for addressing the challenges that I've outlined there. And we should think broadly about what we mean by the term biomarker, so I've put a definition up there. They're characteristics that can be objectively measured and evaluated as an indicator of normal or pathological or responses to or pathological processes or the responses to a therapeutic intervention. So they're not, we tend to think of biomarkers as a molecular entity almost invariably, but actually imaging is a biomarker in arthritis. But unfortunately, despite the availability of imaging, these do very little to help in diagnosis of the subtype of arthritis, and they do practically nothing at all to try and determine prognostic outcomes. We think commonly of circulating biomarkers like the pentamer CRP here, or even ACPA. They're readily available, they're inexpensive to do. But sadly, they too have been somewhat disappointing in predicting responses to treatment and selecting patients to go on the correct treatment at the beginning. So many of us in this room have turned our minds to the target tissue of the inflammatory arthritis in the hope of identifying biomarkers there. So the biomarkers may be, for example, the CD68, which has been shown at a population level to correlate with disease activity and response to treatment. And that's simple cellular counts, I guess, but the synovium can be examined at multiple levels, including the molecular. I'm increasingly coming to believe that actually it doesn't really matter how you biopsy the synovium once you get a good sample, whether it's arthroscopically guided or sonographically guided. What are the things that you can do with it? Well, you can stain for H&E and immunohistochemistry. You can do the explant experiments that Doug described earlier, so I won't explore them any further here. You can grow out the synovial fibroblasts, which we now understand have executive functions in the joint as distinct from passengers. Of course, we talked about the molecular possibilities to be explored. And finally, metabolics is increasingly an opening field in studying the synovial tissues. But a key point that we should remain at the back of our head whenever we're thinking about synovial research is that the rationale for synovial tissue analysis is based on the assumption that the changes seen in the samples truly represent the inflammatory process that's active in the joint, and that they in turn correlate with the systemic inflammatory process. So the prevalence of synovial biopsy in clinical practice is not well known. In the context of translational and basic research, a PubMed search last week simply for synovial biopsy yields almost 20,000 results. And if you look at the results year on year, they're ever increasing. So there's no doubt that from a basic research and a translational research level, synovial biopsying is becoming more common. We're all becoming much more familiar with it. We feel comfortable about it. The outcomes again and again have been shown to be very tolerable. That the outcomes in respect of tolerability to patients have been shown, whether by arthroscopic or ultrasound, to be very well tolerated indeed. So the ESSG agenda, we know that the diseases we treat in the rheumatic diseases world are a heterogeneous bunch of diseases, but the ESSG wants to seek a consensus on statements to develop minimum requirements regarding the sampling procedures, the preservation and storage, which Roger has talked about, and pre-analytical steps. But also, actually, I would add to that and say we also want to have homogeneity and uniformity in reporting, in analysing in the first instance, and then in reporting the data. Because at this point in time, there's significant heterogeneity, I would contend, about how we report things, and I hope I'll give you a couple of examples of that. And as well as that, the other three main platforms that ESSG wants to do is disseminate the information, educate, exchange information, and advance research in a collaborative way, and that's why we're all meeting today. I think it's fair to say that this represents the first attempt to try and seek some kind of standardization in synovial biopsy, certainly in synovial biopsy retrieval. And it goes back as far as 7 years ago. And they made a number of key recommendations, which have been gone over in other talks this afternoon. The sampling should be from 6 to 8 different sites within a joint, and that's not an arbitrary number, as we've seen. That's selected because, on average, there's a less than 10% variance of the CD3 counts when you take that many biopsies. So it's much more representative. But when you have a port in a joint, and as I said, I declare completely that I was exclusively involved in knee biopsying, it's as well to take as many biopsies while you're in there as possible. So I encourage people to take as many biopsies as possible once the port is in situ. And then the recommendations of the paper deal with stuff that Roger has actually talked with. So I put them up there for completion, but I don't want to go through them in any detail. In fact, what I want to concentrate on are the limitations of what was proposed in 2011 in regards to standardization. So no recommendations actually were made at all in respect of quality assurance. No recommendations have been made in respect of scoring samples for cellular or for immunological infiltrates. And no recommendations for the reporting of the data in the papers that were to be published on it have been made. So we're operating significantly in a vacuum, and a less, maybe somewhat esoteric point is that most of the data on synovial research concerns ORA, because of course that's the most prevalent inflammatory arthropathy. The knee is involved in about 8% of patients who have rheumatoid arthritis. So we're not entirely certain that biopsying the knee is the most appropriate thing to do in that setting, and certainly the ability of our sonographers to look at the small joints may still be relevant, and certainly recruits a lot more patients to retrieve tissue from. What we do know is that in the study that's already been mentioned, no differences in cell numbers between the tissue retrieved from an inflamed knee and that retrieved from an inflamed wrist or MCP. So these are the poor 9 volunteers who agreed to have biopsy of both a small joint and a large joint. And as I mentioned earlier on, we know also that patients who have clinically involved joints have similar cell counts in their synovium taken from an apparently clinically uninflamed joint. So the definition of quality assurance or histology quality has been somewhat elusive, although I think we've made some steps towards achieving a consensus in this regard. Some have proposed, of course, this concept of the presence of the lining layer, and it's often used to define that this tissue is definitely synovial tissue, but it's variably actually reported in the literature. I think it's worth noting as well that depending on the technique used to biopsy, your chances of collecting a lining layer is greatly increased if you're biopsying from the cavity of the joint. So in some applications, others have argued that it's not really the presence of the lining layer at all that matters. You're looking at a different tissue subtype, and it depends on the application, the tissue that you really want to get. We always have a little bit more confidence when we do collect a lining layer because we're certain it's synovium. I've mentioned already that the lining layer is more likely to be collected from biopsies within the cavity of the joint. And there's very limited consensus actually on what constitutes quality standards for the biopsy procedures, but we'll talk a little bit more about that later, and Roger has touched on it and the work of the ESG and orally in that regard. So, to move on to the minimum standards in analysis and then reporting, concentrating almost exclusively on H&E staining and immunohistochemistry, I'm afraid to say that there's significant heterogeneity in methodologies and in reporting. And I'm going to give a couple of examples in the relatively recent past in the literature to demonstrate this heterogeneity. Some of them are some of my work, and some of them are some of Cos's work and so on. But I want to emphasize, I in no way advocate that there's one way better than another. I simply show these examples to demonstrate the heterogeneity of an analysis and then reporting. So this is France's recent publication, and this piece of work is absolutely extraordinarily elegant, to be honest. It's been a really concerted, constructive, well constructed study to answer a clinical question that's hugely important, and it's very diligently reported. I just want to bring it down to the points. So number one there, the number of graded synovial tissue fragments. 2, the number of synovial, total number of synovial tissue fragments. The total area of graded synovial tissue. Francis has gone through this a little bit earlier and used CellSense dimension software in this regard. And then a quantitative scoring system for the severity of the synovitis on a scale of 0 to 9. We'll look at that in a moment. And that's how she's reporting, or their group are reporting their synovial tissue findings in this instance. Another recent paper, for H&E staining, slides are scored for levels of inflammation over 3 ordinal categories, 0 to 3. And then sections were scored by 2 reviewers independently, and each were blinded to the tissue source. Differences in the scoring between observers were reviewed together, and a consensus achieved in each instance. So here you see that we're reporting quite differently to how our colleagues are. And we really need to get some harmony, I think, in how we do that. That's simply with H&E staining. The situation is similar when it comes to immunohistochemistry. Dating back to 1997 at one of Paul Peter Tack's presentations, extraordinary efforts have been made in this paper to try and accurately depict scores for immunohistochemistry. And And as you can see, they have a semi-quantitative score there, but they also add scoring for hyperplasia of the synovial lining layer, and then a separate inflammation score. And it's the sum of these that ends up giving a total inflammation score. We use a well-established semi-quantitative scoring method with scores ranging from 0 to 4. This is published elsewhere. Another semi-quantitative methodology for appraising immunohistochemistry samples. Sections again reviewed by two reviewers independently in both the lining and the sublining layers, and differences in scoring between the observers were reviewed together and consensus achieved in each instance. Not universally reported. What's the training of the people who are looking at these biopsies? How many people are reading the biopsies? These are not routinely reported. And then another example, again very recently, using the same semi-quantitative scale, but again not reporting on inter-observer agreement and so forth. So there's a need for standardization is what I'm saying, and the need goes right back to the beginning: cohort selection, the methodology for collection and so on. Roger has talked about handling issues and achieving some harmony in how we do that. But I think we still need to achieve harmony in the analysis of the tissue itself and in the reporting in the literature. This is probably the first and only known validated synovial tissue scoring system for H&E staining developed by Kren back in 2006. And he essentially has a score out of 9 broken into 3 parameters, each scoring between 0 and 3. And he breaks it down to enlargement of the synovial layer itself. The synovial stroma shows the density of the resident cells in the stroma proper, and then separately the inflammatory infiltrate. And it's the sum of these 3 parameters that gives you a score out of 9. This is the example image in the paper, and as you can see on your left, the lining layer is getting progressively larger from top to bottom. In the middle section, the density of the stroma is increasing from top to bottom. And on the extreme right, you see that there's more inflammatory cells populating the synovium from top to bottom. Immunohistochemistry, there's a number of different ways that the tissue can be scored. A quantitative analysis implies choosing a high power field of whatever magnification, we'd have to be consistent about it, and then manually counting the cells that are stained. It's very sensitive, but it's extremely time consuming and probably most appropriate for small studies. A semi-quantitative analysis is used more widely, and that goes back to the 0 to 4 scoring system that I've explained on slides preceding this one. It's pretty quick and highly specific actually, but insensitive to small changes, and it's probably suitable for very large numbers of samples. And then computerized digital image analysis is increasingly becoming available to us. Do we have any hint that we're on the right road to being able to report synovial tissue findings accurately? We can take solace, I think, from a seminal paper that Terence Rooney worked on back in 2007. I just want to go through this in a small bit of detail because it's a nice study that does answer the question, or at least gives us some reassurance, I think, that we're at least on the right path. They took 12 patients with active RA in the knee joints and arthroscopically retrieved tissue from there. They had 6 centres involved, and the same 12 coded slides for each subject stained both for CD68, a macrophage marker, and CD3 were sent to each centre. And in all centres, quantitative and semi-quantitative scoring was done, and in 3 centres, computerised digital image analysis was also done. And the results are actually reassuring, actually. The overall level of inter-observer agreement was quite high, especially for semi-quantitative analysis, but that's at the cost of some sensitivity. But even for quantitative and for digital image analysis, wherever the centre, they were reporting fairly similar results. So let's have a look at how we score synovial tissue with immunohistochemistry scores. But as I show you the next few slides, which are just simply exemplar images, I want you to watch for differences in the patterns of staining and ask, is a single score suitable for all the stains and all the known pathotypes? Is a 5-point ordinal scale sufficiently sensitive? Note that in these instances, a lining layer is present because they were all arthroscopically retrieved. And then I want you to observe, is there potential that we might disagree on the score? And importantly, there's differences in antibody exposure, and I've got one image that might exemplify that. So the first one is CD68 cell stain, a macrophage cell. We're looking at the sublining. This would be scored at 4 because it's between 75 and 100% staining. So it's a clear-cut macrophage infiltrate throughout all the stroma. CD4, a subset of T cells, and excluding the lining there because we're exclusively looking at sublining, this would score 1 because it's between 0 and 25% staining. This is another CD4 image, but clearly a lot more staining, and this again scores 4, again between 75 and 100%. CD4 again scoring 3, between 50 and 75% of staining. So there's reasonable reproducibility with these. CD4 stain, we scored this 4. And this is the image for a PANS T cell marker CD3. And you can see that the slide has probably been actually overexposed during the processing. But if you look carefully, you can actually see that it's the cells that are staining, although there's some artifact in the stroma itself. And this too would score 4. Here you can see a very clear organization of the CD3 cells in the lymphoid follicle, but also scattered lymphocytes throughout the rest of the stroma. And this scores 3. And just to show you what a vascular stain, I put this in. We don't score it in the same methodology, and I'm not going to go into how we might do that, but that's what a vascular stain looks like in the synovial tissue. So there are currently clearly recognized pathotypes in synovial tissue from rheumatoid arthritis patients. And these are the sample taken from Costas' paper, a follicular type, a diffuse type, and a POSI immune. And they're the various stains. You can see that there are clear differences. But it's important to recognize that while some patients can easily be put into one of these subsets, there's many, many patients, and this is the image that I showed you just before that, who have both a stromal infiltration but also an organized lymphoid aggregate. So these patients can exist on a spectrum. So what can be reported in our papers? The quantity, the quality, the joint compartments, where did we take the tissue from, what was the whole tissue section area, the lining layer thickness and cells, the degree and grade of lymphoid organization or secondary lymphoid organs, definitions of what such organs actually are, the presence or the absence, or do you score them separately, talk about T and B cell segregations, whether there's neoangiogenesis, and if there is, how do you report that? Should we be including the number of observers and their level of training and experience? And how were the inter-observer consistency? How is that reported? And what were the mechanisms for resolving discrepancies? And this is by no means repeat. So it's clearly not tangible or practical to have all these reported in all synovial literature, but we must decide on what should be minimum standard reporting. There should be some statement of quality assurance. There must be some statement about how the analysis was done clearly. And then because CD68 remains the only biomarker from a cellular point of view in synovium that has been associated with clinical response to treatment, we should probably be reporting that in nearly all our studies. And the ESSG have gone to great lengths to try to do that, and Orly and Doug have led this project. 27, I mean, it's very similar to, it's the same project that Roger talked about, so I'll go through it very quickly. There are 27 ESSG members from 19 centres contacted by email. 20 of them from 17 centres responded. 19 of the 20 were rheumatologists. One was a pathologist. And they used the modified Delphi method that Roger elaborated on previously. And the final third round was a face-to-face meeting at the EULAR Annual Congress in 2017. They used a 5-point Likert scale for each statement, and then selected that statement to go forward to the next stage if it had a median score of greater than 3.5 and more than 70% agreement amongst all participants. So in relation to quality, the biopsy size above 2.5 millimeters and the preserved lining layer were seen as good quality criteria, and the overall morphology of the tissue should be preserved. But that's a very broad statement. Items regarding minimal requirements for reporting in the number of vessels, the percentage of stroma within the tissue required for quality check did not reach any consensus. In respect to staining and immunohistochemistry, H&E and CD68 staining were considered to be sufficient for histopathological analysis, although some additional staining such as the B cell stains, T cell stains, plasma cells and vascular markers could be used when clinically relevant in the clinical setting. A semi-quantitative analysis was favoured by most and scored greater than 3.5 and more than 70% consensus. So that seems to be the way most people will want to report their data. It's less time consuming in clinical practice, clearly, but a quantitative analysis can also be performed depending on the requirement. In translational research, the group proposed that we widen the stains that we use to include definite vascular markers. B cell and T cell should almost invariably be reported. So the interpretation and the reporting of the biopsy, the synovitis score should be performed, but no preference was expressed regarding what that score should be, and whether it should be, for example, the proposed Crane synovitis score. Lining layer hyperplasia scoring was recommended only for translational research purposes, not in the clinical setting. And the synovial pathotype should be described, although some emphasised that it wasn't clear which features made the synovial pathotype. And it was agreed that the presence or absence of ectopic lymphoid follicles within the membrane should be described. So in clinical practice, there was a lot of disagreement about what pathologists should be asked to do, but clearly the finding of granulomas was a clinically important finding. For multiple biopsies, most felt that results should be expressed as an average score of the total number of the biopsies analysed, and if a single biopsy is to be analysed, at least 3 different areas should be assessed to ensure reliability. No consensus on the need to report vascularity scores in clinical practice or in translational research were achieved. So to close, there's many unanswered questions, and we're relying on expert opinion at the moment to develop a protocol or agreement or consensus or harmonisation about how we report our findings and how we interpret them. Biopsying the synovium may be studying the disease in a late phase of disease. We know that. It's difficult, I think, at this point to advocate that everybody should have a synovial biopsy who presents with arthritis. Clinical trials are expensive, they're not mechanistically driven, so the utility of synovial biopsy and that is absolutely vital, I think, and can reduce the cost significantly of those. And to advance further, it's really essential that we come to a consensus and agree that there should be some homogeneity in reporting our data. And I'll leave you with this final statement, which I thought was quite sage. A mystic and dangerous assumption prevails in the mind of the clinician that the pathologist can produce a statement of absolute truth based on a small piece of tissue. So thank you for your attention.